Welcome to our video on non-infectious ulcers. Let's get started. Here is an overview of what we'll be covering in this lecture, and we'll start with pressure ulcers. And here are the topics that we'll be discussing for pressure ulcers, starting with definition. Pressure ulcers are injuries that are caused by constant and unrelieved pressure to a specific area of the body. Pressure ulcers are also called decubitus ulcers or pressure sores. The pathophysiology of pressure ulcer stems from the continuous pressure, as we previously mentioned, particularly over bony prominences. This constant pressure leads to the hypoperfusion and ischemia and can eventually progress to tissue necrosis that in severe cases can lead to loss of skin and soft tissue. Risk factors for developing pressure ulcers include conditions that subject patients to prolonged duration of limited mobility. These include elderly, bedridden patients. Malnutrition also imposes a big risk, as adequate nutrition is essential to ensure the body and tissue is viable. Now, patients with conditions that limit or decrease their sensory perception, such as diabetes mellitus, and patients with neuropathies are also at risk. And this is because patients with these conditions don't tend to realize they've been injured due to the lack of pain sensation, which leads to late detection of the injury. Urine and stool incontinence can cause skin macerations and irritation, which only adds additional strain to the affected skin area. Patients present with painful burns, excoriations, and ulcers of various degree of injury overlying the bony prominences. Typically affected areas include the sacrum, ischium, and heels, but any area subjected to constant unrelieved pressure can be affected. The degree or level of injury depends on the stage of the ulcer. It ranges from local tissue and superficial skin changes to very deep injury that can reach the bones. It initially starts as erythema that is non-blanchable and skin discolorations. When the dermis is exposed, the injury will appear red and moist. More severe stages will involve full-thickness skin loss and eventually eschar formation and necrosis. And muscle and bone can then be exposed. Other associated findings can occur due to possible tissue infection and include purulent drainage. Here's a schematic image showing all skin layers and underlying tissue affected by pressure ulcers in 4 different stages. This is the epidermis, then the dermis, hypodermis, and then the muscle and bone tissues. Notice how the higher the stage, the more severe and the deeper the injury is, with stage 4 being the most severe, reaching the bone. This is an image showing a pressure ulcer in one of the earlier stages. We would call this stage 2. And notice the skin erythema and the dark discoloration of the lesion. So this is an image of a pressure ulcer in stage 3. Here you can see the loss of all skin layers with the involvement of subcutaneous tissue. And here we can see an advanced stage of a pressure ulcer, or stage 4. There's extensive tissue damage with loss of all skin layers and involving deeper structures. You can also see the exposed, damaged muscle. Diagnosing pressure ulcers is mostly done clinically, and then ulcers are staged from 1 to 4. Assessing predisposing risk factors is essential for prevention of future ulcers and for guiding management. Testing for glycated hemoglobin, or hemoglobin A1C, to test for uncontrolled diabetes mellitus in non-diagnosed patients, and then testing for malnutrition by measuring albumin levels can also be done. In patients with suspected ulcer infection, a CBC and inflammatory markers, such as a C-reactive protein, can be done to detect a possible infection. Now, a swab from the lesion can be done to identify the causative microbe. So if there's an ulcer that doesn't seem to be healing, a non-healing ulcer, despite appropriate measures, a biopsy can be considered to rule out malignancy, or to identify resistant infections and rule out pyoderma gangrenosum. Recall that pyoderma gangrenosum is a condition associated with autoimmune inflammatory diseases and results in rapidly enlarging, painful ulcers. Remember that the best management for decubitus or pressure ulcers is the prevention of their occurrence. This is done by eliminating or managing the risk factors, pressure redistribution with the addition of supporting soft surfaces for areas at risk, and repositioning the patient every 2 hours. Once an ulcer is developed, appropriate wound care, including debridement of necrotic tissue and pain control should be carried out. Wound dressing, such as hydrocolloid dressing, is important to keep the wound moist and to absorb the exudate. Now, if infection is present, appropriate antibiotics and treatment for that infection should be administered. Finally, ensuring adequate nutrition is important to both help tissue recovery as well as prevent further damage. A 43-year-old man presents to the physician for a follow-up examination after being treated for pneumonia 2 months ago. He is a paraplegic and has been in a wheelchair for 5 years after sustaining major injuries following a motor vehicle accident. On physical exam, pedal pulses are present bilaterally and dilated veins are present on both lower extremities. There is a 1.5 centimeter ulcer present over the left calcaneus. What is the most likely cause of this patient's ulcer? Okay, so let's take a look at this question closely. This patient is a paraplegic, therefore he has significantly limited mobility. And the presence of an ulcer over the calcaneus, which is a pressure point, makes it highly suggestive of a pressure-induced or a decubitus ulcer. And the fact that he has varices on his legs might make you think of venous ulcers as a differential diagnosis. And we discuss venous ulcers in detail later in this lecture, but pressure points, including the calcaneus, are classical points affected by decubitus ulcers. Now, important things to remember include prevention of decubitus ulcers by frequent patient repositioning or pressure redistribution, and ensure that they're treated with wound care and hydrocolloid dressings. Okay, next let's discuss arterial ulcers. Arterial ulcers are complications of peripheral artery disease due to the atherosclerosis impeding normal blood flow to the extremities. Eventually, this leads to tissue hypoxia, necrosis, and ulcers. Risk factors include those of peripheral artery disease, which are diabetes mellitus, smoking, hypertension, and dyslipidemia. Each of these pose an independent risk factor to the development of atherosclerosis and peripheral artery disease. When arterial ulcers present, they are extremely painful. Now, these ulcers appear punched out with well-defined borders, and they're usually present distally on the toes, especially on pressure points, such as the tip of the toes and the lateral malleolus. And it's very important to learn the classical locations of the different ulcers, as it's a high-yield concept commonly tested on the boards. Associated symptoms that could be present in patients alongside the ulcers are symptoms of peripheral artery disease and include leg claudications and cold and pale extremities due to the decreased blood flow. Here is an image of an arterial foot ulcer in a patient with peripheral artery disease. Notice the location of the ulcer being on the tip of the great toe. This is a classical location of arterial ulcers. History and physical exam can give great clues as to the nature and cause of the ulcer. Patients may have a history of a myocardial infarction, or may report a history of leg claudications and pain that is relieved with rest, worse with activity. On inspection, the extremity may appear pale, shiny, with thin skin, and it might have decreased hair density. And note that all of these are signs of peripheral artery disease. Additionally, peripheral pulses will be decreased. The extremities will be cold, and if you test their capillary refill time, you'll notice that it's prolonged. Now, capillary refill time is the time it takes for the capillaries to be refilled back with blood after the application of pressure on the body, usually by pressing your fingers there. And a normal refill time is less than 2 seconds. But in patients with peripheral artery disease, this time is prolonged, suggesting a disturbance of blood flow. The first-line diagnostic test is the ankle brachial index, which is both sensitive and specific for detecting peripheral artery disease, and therefore can confirm that the ulcer arose as a complication of peripheral artery disease. And we actually discussed the details that pertain to peripheral artery disease in another lecture. But for the purposes of this lecture, let's briefly discuss the ankle brachial index. This index measures the ratio of the ankle systolic blood pressure to the arm systolic blood pressure. In other words, the ankle blood pressure is being compared to the arm blood pressure to detect the difference and identify the severity of the disease. The normal ratio is considered to be between 0.9 and 1.3, with severe non-compressible arterial disease having values of more than 1.3, and claudications occur with values between 0.4 and 0.9. and pain at rest occurs between 0.2 and 0.4. Now, imaging methods such as Doppler ultrasound and CT angio can also be performed and will show evidence of stenosis. Management of patients with arterial ulcers includes modification of risk factors of peripheral artery disease and atherosclerosis in general. Now, this includes antiplatelet therapy, namely aspirin and clopidogrel, smoking cessation, lipid-lowering agents, namely a statin, and then treatment of diabetes and hypertension, if those are present. Additionally, the patient should be started on a trial of supervised, or if not possible, unsupervised, exercise. So you want to get them exercising. The exercise program is recommended for 30 to 40 minutes, about 3 to 5 days a week. And in the case of severe impairment, significant symptoms, or patients who are not responding to conservative treatment, revascularization procedures should be considered. Now, choosing revascularization as a treatment really depends on the patient's risk assessment, the extent of the disease, along with other criteria. And in the case of gangrene or abscess, surgical debridement can be done. Now, limb amputation is reserved as a last option for irreversibly damaged and a severely compromised limb. Here's an image showing an example of bypass surgery to restore the blood flow to the distal part of the legs beyond the obstruction. All right, now let's move on to venous ulcers. Venous ulcers are complications of chronic venous insufficiency due to the venous stasis that eventually leads to tissue damage and ulcerations. Now, skin findings associated with chronic venous insufficiency are referred to as stasis dermatitis. Chronic venous insufficiency occurs due to incompetent venous valves allowing backward flow of venous blood and venous stasis. So instead of coming back up to the heart, they just keep pooling down in the legs. Now, this stasis of blood results in capillary damage, edema, and tissue hypoperfusion, leading to skin changes and ulcerations. And the fact that this venous stasis causes hypoperfusion is pretty logical when you think about the fact that the veins are actually carrying deoxygenated blood back to the heart. So if they're just pooling there, then new oxygenated blood can't go to those tissues. So you just have this old deoxygenated blood sitting there and letting the tissues experience ischemia. Risk factors for venous ulcers are those of chronic venous insufficiency. Now, these include advanced age, family history of things like this, prolonged standing, and recurrent DVTs. Venous ulcers are mildly painful, and they're less painful than arterial ulcers, which, as we mentioned before, are extremely painful. Most commonly, venous ulcers are located above the ankle at the medial malleolus. And recall that this is in contrast to arterial ulcers, which tend to be located at the tip of the toes and at the lateral malleolus. Other associated findings that may be present include varicose veins, trophic leg changes, and edema, which are all findings of chronic venous insufficiency. Here's another image. So this actually shows an advanced stage venous ulcer. Notice the location at the medial malleolus. This is an important feature of venous ulcers. And here's an image of a patient with chronic venous stasis due to chronic venous insufficiency. Notice the skin discoloration and the edema, which may be evident. Now, diagnosing venous ulcers is actually done by diagnosing chronic venous insufficiency. So patients may have a history of claudications that get better with leg elevation, which makes sense because that facilitates the venous drainage going back to their heart. And the imaging method of choice for diagnosing chronic venous insufficiency is a duplex ultrasound. That can evaluate the presence of venous reflux, as well as to assess the extent and severity of the venous reflux. Management goals of chronic venous insufficiency is to relieve symptoms and reduce the edema and prevent complications such as ulcers and skin changes. Now, ulcer care is an important step and includes wound cleaning and coverage. So you want to cover it. And you want to give antibiotics for infections, and if any necrotic tissue is present, you're going to want to do debridement. Now, leg elevation up to the heart level is recommended for 30 minutes to 40 minutes daily. This improves the edema, skin microcirculation, and can relieve the symptoms. Now, exercise, such as daily walking and simple ankle flexion, can increase the efficiency of the calf muscle pump and venous drainage. Compression therapy is also an essential part of managing chronic venous insufficiency. And this compression therapy helps prevent venous pooling, and therefore it prevents those complications associated with venous insufficiency. So, okay, now skincare for the pruritus, dryness, and fissuring present in stasis dermatitis is also important. Now, proper skin cleaning and the use of emollients are important to reduce the itching and the scratching, and you're going to help prevent skin ulceration from worsening. Now, lastly, pharmacologic agents such as vasoactive drugs can be attempted for the treatment of resistant edema. A 65-year-old man comes to the physician due to a painful foot ulcer on his toe. He does not recall any injury to the area. Over-the-counter creams have not helped. His history is significant for coronary artery disease and hospitalization for acute myocardial infarction 3 years ago. He's a lifetime smoker. Physical examination reveals cold distal extremities and a painful ulcer on the tip of the great toe of the left foot. On palpation, pedal pulses are decreased bilaterally. What is the management of this patient's condition after his diagnosis is confirmed? So hopefully from this question, you see that this patient most likely suffers from peripheral artery disease with an arterial foot ulcer as a complication. This patient's history of coronary artery disease, myocardial infarction, and his smoking history all predispose him to peripheral artery disease. Now, these arterial ulcers need initial wound care with wound cleaning, debridement of necrotic tissue, if present, and wound dressing to protect against infection. After that, management mainly focuses on modifying risk factors of atherosclerosis and peripheral artery disease. Now, this includes putting patients on antiplatelet therapy, so aspirin and clopidogrel, lipid-lowering agents, such as a statin, as well as smoking cessation, and treatment of diabetes and hypertension, if those are present. Now, a supervised exercise program is also important. In severe cases, like we mentioned before, revascularization may be needed in order to restore blood flow to the limb. Now, if the damage is extensive and irreversible, amputation may be considered. All right, now let's move on to the last topic, neuropathic ulcers. Neuropathic ulcers are ulcers occurring as a result of a neuropathic condition due to the lack of pain sensation. The decreased sensation leads to the inability of patients to recognize painful or uncomfortable stimuli. These patients, therefore, don't shift their weights, leading to the constant pressure and injury in those ulcers. Now, due to the lack of pain perception, patients don't notice or recognize that they've been injured, and injuries can worsen and, of course, those ulcers will form. The single biggest risk factor is diabetes mellitus. Other conditions that can cause neuropathy include spinal cord disorders, alcohol abuse, and nutritional deficiencies such as vitamin B12 deficiency. Neuropathic ulcers present as painless ulcers that are punched out with a thick callus. They tend to be found on pressure points on the foot and heels. Associated findings of diabetes can be found as well. And those diabetes findings that you're thinking of are diasthesia, or a burning pain, a loss of sensation over the affected area, as well as a dry, scaly foot. A 66-year-old woman comes to the physician because of an ulcer above her ankle that she first noticed 3 weeks ago. She says it's mildly painful and does not recall any trauma to the area. She has undergone sclerotherapy in the past for recurrent varicose veins. Current medications include atorvastatin and ibuprofen for chronic back pain. On physical exam, a 2-centimeter ulcer is present over the medial malleolus. There is brown discoloration of the lower extremities bilaterally, as well as edema. Okay, so hopefully from this question, you got that this patient most likely suffers from chronic venous insufficiency. We know this because of her history of recurrent varicose veins, as well as the brown discoloration and edema present bilaterally on her lower extremities. Those are all classical signs of chronic venous insufficiency. Now let's take a look at the location of the ulcer, because that becomes essential in identifying the likely cause of the ulcer. Now, this patient's ulcer is present above her ankle over the medial malleolus, which is one of the classical locations of venous ulcers. Let's also quickly review the locations of other ulcers that we discussed. Remember that decubitus ulcers, or pressure-induced ulcers, classically present at pressure points overlying bony prominences such as the sacrum, ischium, and the heels. Arterial ulcers classically present at the tip of the toes and the lateral malleolus. Finally, neuropathic ulcers also present on pressure points, but these will be painless which is a very important distinguishing feature of these. So, this patient's ulcer that is mildly painful and located over the medial malleolus is most likely a venous ulcer, which is a complication of chronic venous insufficiency. So now let's get back to our discussion on neuropathic ulcers. So the diagnosis of neuropathic ulcers involve the presence of a painless ulcer, which differentiates it from the other types of ulcers that we've previously discussed. And on sensory examination, decreased sensation of the affected limb will be evident. Other complications of diabetes, such as diabetic retinopathy or nephropathy, could also be present. Laboratory evaluations of hemoglobin A1C to assess diabetes and how well it's being controlled, as well as a CBC to assess for a possible infection, can also be done. Now, bone imaging should be considered, especially if the bone is visible or in deeper ulcers where there's a high risk of osteomyelitis. Management of neuropathic ulcers begins with a thorough assessment of the ulcer. First, the ulcer grade, which determines the depth, and ulcer stage, which determines whether or not it's infected. So you got to establish those two things. Now, in case of pus or other signs of infection, a culture should be obtained to determine the agent. After that, empiric antibiotic therapy should be initiated once the infection is confirmed. Now, if osteomyelitis is suspected, imaging such as an X-ray should be performed. Now, local wound care, such as debridement of necrotic tissue and dressing of the wound to keep it clean and prevent infections, are important for wound healing. Mechanical offloading, or avoiding mechanical pressure, and decreasing the weight on the foot through better fitting shoes with good heel support can actually also be helpful. Also, avoiding walking barefoot is important to prevent more foot injuries. And that makes sense. If you've already got this foot that can get injured and not know it because the patient can't feel pain, you want to make sure they don't get any more injuries or step on a tack and not know. So make sure they're avoiding walking barefoot and they have that protection. Now, patients need to be educated on their lifetime increased risk of developing foot ulcers and
the importance of regular foot evaluation.
Now, patients need lifetime follow-up twice each month for early detection and prevention of more ulcers. Now, here's a table that summarizes the 4 different ulcers we discussed in this lecture, including their most important differentiating factors. These ulcers are extremely high yield for the boards, and questions comparing the locations, risk factors, or clinical presentations are very common, so make sure you learn these well. Let's wrap up with a board-style question. A 61-year-old man presents to the emergency department due to a painful foot ulcer on the medial malleolus. He says that he has difficulty walking and has to stop frequently to rest due to leg pain. His history is significant for coronary artery disease, hypertension, and diabetes mellitus type 2. He was previously hospitalized for an acute myocardial infarction. He is a lifetime smoker. Current medications include atorvastatin, metformin, lisinopril, and aspirin. BMI is 34. Blood pressure is 148/85, and pulse is 85 per minute. Physical examination shows decreased bilateral peripheral pulses, cold extremities, and decreased hair on both legs. Laboratory results show a hemoglobin A1C of 7.5%. What is the next best step in diagnosis? A. Duplex ultrasound. B. CT angiography. C. Biopsy of the ulcer. D. Ankle brachial index. Or E. Nerve conduction studies. Hopefully from this question, you got that this patient most likely has peripheral artery disease and an arterial foot ulcer as one of its complications. Therefore, the best next step in diagnosis is D. Ankle brachial index. So he has a history of coronary artery disease and hypertension, as well as uncontrolled diabetes with an hemoglobin A1C of 7.5%.
You recall the goal is less than 7%.
And those are all risk factors for peripheral artery disease. Additionally, physical exam shows decreased bilateral peripheral pulses, cold extremities, and decreased leg hair. Recall that arterial ulcers are suspected in patients with peripheral artery disease, and the best step in diagnosis is actually the ankle brachial index. Now, this index compares the ankle systolic blood pressure to the arm systolic blood pressure because it can help distinguish the difference and identify the severity of the disease. So let's go back to our question and see why the other answer choices are incorrect. Answer choice A is incorrect because even though the duplex ultrasound can show arterial stenosis, it's not the best initial step. Option B is incorrect because although CT angiography is used to identify atherosclerotic arteries, it's invasive and it actually subjects the patients to radiation, and it's just not the first step in diagnosis. Now, biopsy of the ulcer, option C, is incorrect because it's too invasive and other possible diagnoses must be ruled out first. Biopsy of an ulcer is indicated when malignancy is highly suspected in a non-healing ulcer. And finally, option E, nerve conduction studies, is incorrect because this test is used to identify neuropathies. Now, even though this patient has uncontrolled diabetes mellitus, there's no evidence on physical exam of loss of sensation. Additionally, the foot ulcer is painful, which is not the case in neuropathy. Therefore, the correct answer is D, ankle brachial index. And that concludes this section.